Welcome. Thank you all for joining us today. I have the pleasure of interviewing Dr. Stephen Bush today, an OBGYN practitioner who's going to recount his experience with adoption of electronic health records, the whys and wherefores. So, Steve, would you tell us a little bit about your practice?
We're a large multi-specialty practice in St. Charles. We have both obstetricians and pediatricians, as well as some of the specialists that go along with both those fields. We have 22 providers currently, and have grown over the last 10 years to this point.
What made you think about the adoption of an electronic health record? I understand you've had yours up for about 5 years now.
We were an early adopter of EHRs, and the reason for that was mainly because it gave us the opportunity to go to multiple offices as well as keep track of information in a much more concise manner. A lot of times charts were in doctors' cars, charts were in different parts of different offices. We had more luggage than we knew what to do with by transporting records between different offices, as well as when patients needed their records, we didn't have the access to them that we needed, as well as it helps us with being in the hospital so much. So now it was clear and concise for all of our physicians that we were able to know what the other person was doing, so that if you did take care of, especially OB is a great example, or even when you have a sick kid come in, the usual physician might not be the treating physician of that time,
right.
And that way we were able to access that information in a clear, concise manner.
When you think about that first 6 months or year of your implementation, what was the biggest obstacle you struggled with in implementation of an EHR?
Well, I think two of the biggest obstacles. One is EHR companies don't understand how medical practice run. They understand how to make an electronic medical record. Right. So when we sat down with them, the way that they projected our practice to run, and we've done it differently, was each doctor developing their own templates, each doctor coming up with their own pathways, where we adopted early on, and I think now with all of meaningful use, we're actually now ahead of the curve, way ahead of the curve, is that we adopted a protocol-based.
Well, and I think the benefit of the tack that you've taken in terms of a more standardized approach to information and where it sits is critically important, because you can imagine the challenge if you had 22 providers who kept the same bit of information in 22 different ways in terms of the way they practice. That I think, biting that bullet on the front end and just and taking a more standardized approach to it, that way when your staff goes to find information, it's going to be so much easier for them. So the economies of scale may come as everyone becomes more fully aware and understanding of where information is and what you're going to use it for.
Well, and also accountability is very important, because now we have a way to track accountability of our physicians. So where we used to have doctors who would have stacks of charts, including myself, on our desks that we saw the patients 2 days ago, but we haven't gotten around to charting on them. Now we can capture and say within that 24-hour period, for us it's a 24-hour window, that if they haven't charted, we can capture that right away and say, you have to get this completed.
Sure. And
basically utilize that from an accountability standpoint. Because really, for physicians, it's yes, they have to get their charting done, and eventually they do. But as we know with medical records at the hospitals, getting them in, getting the charting done, if they run out to the hospital, what's nice now is that they can chart from the hospital, they can chart from home, they can chart from anywhere and be able to complete their records, so that we're not losing information that we would have lost if they had forgotten something to chart in a handwritten type chart. I think it's the access. The access, the ability to know what the other physician was doing, the ability to know what they were doing, the ability for our triage nurses to be able to pull that information off so that they're not getting stacks of phone calls at the end of the day, to make that everybody is able to understand exactly what the care plan was for that patient.
When you think about if tomorrow you were gonna go out into the EHR world and start this process all over again, what are the do-overs that you learned from your initial implementation of the EHR? What would you do a little bit differently, or maybe a lot differently?
There's a lot of things that you probably looking back at it, would do it differently. How some of our computer infrastructure. I think one of the hardest things to understand when you're purchasing an EHR is really what computer infrastructure you need. A lot of the EHRs want you to adopt certain types of architecture, certain types of, at that time wireless was big, but nothing of the ability that wireless has now. So we were all wireless, and our computers kept shutting. You know, the minute they would lose a charge when we were using laptops or tablets, the minute the charge would go down, we'd switch off that platform and wouldn't be able to do that. How robust you needed your infrastructure to be able to, the amount of volume of information that was going across, we used to run into slowness issues and other issues like that made it difficult. Direction has to come from the top all the way down to your basic staff. And really, for us, the reason I think it went as well as it did is we included all of our staff members in this process. It really isn't a physician, it's physician driven because the templates have to be done, but your MAs, your nurses, your schedulers, your billers, everybody has to be involved in the process, and we adopted that early on. The second thing is making sure that you pick people who are your key contacts. We have two, one on each side, who deal with any of the issues that come along. And also motivating the physicians. The physicians have to be motivated to be able to do this. Younger physicians, we found much easier adapters of this because they were doing it already in residency. Older physicians, there's many times where doctors who we brought into the practice, and remember, we didn't just start out with 22, so it's been over the years, who never used it before came in, and you know, there's many times where they came in, you know, ready to throw their laptop against the wall because it's a different way of seeing a patient. An electronic health record and the way you input is so different from what we're used to doing on how we treat patients, and so learning how to do that was awkward.
To get to the point of meaningfully using it, and that's why all the resources that you may have internally, as well as those that the vendor may bring, and then those that the Regional Extension Center may bring. There's a reason that they want to do that, and I think it's because it's not easy work. It's difficult, but at the end of the day, it's the right thing to do to prepare yourself and your practice for the nearly certain changes that are occurring in healthcare as we speak.
Well, I think that's one of the benefits of having the regional extension and having the people to help physicians to be able to do it. We, as you know, were chosen because of our adoption along the way, and also we've been very proactive. We're a much more proactive group about making sure that we understood what was going on 2 to 3 years down the road and trying to adapt to that. The EHR company can only get you so far, and it really is much more than just having an EHR to hit meaningful use. You and I both know this. That even though the EHR companies profess that you'll reach EHR, I don't think everybody understands what it truly means to get to EHR. And that's where regional extension comes in, and the help that we've had from you and your people to come into our organization and explain to us the different aspects of it has taken our lead time and dropped it considerably, and helping us understand, even though I don't think all of us truly understand exactly what the government might want us to do. And I think that's the hardest thing is right now is all the changes that are going on is when you have a group that might not be able to adapt as quickly only because of size and resources. In one of our IPAs, we actually send them information, and it works in our favor because it meets with criteria of the insurance company. Blue Cross Blue Shield now is sending us out data explaining to us different criteria that we've had to meet and their percentages. And then what we're able to do is say, well, wait a second, that percentage is wrong or correct, because they're pulling only billing data.
Sure.
So if we don't bill for it, they don't see it. But if we're doing it still, we have actually the way of going back and saying, wait a second, here's all the data for this, and we can pull that data set out of our EHR.
So the availability of quality data is a positive impact.
Significantly. And in reviews, it's a significant, in audits and all that. If they need their records to another physician, it's very easy for us to get that. It can be done much quicker, and within a short period of time, we're able to now burn it onto a disk, or to give it to them on a memory drive or whichever. Mm-hmm. Also, being able to prescribe to there's none of this where prescriptions are written and the patient loses the prescription or it's the wrong, it's now e-prescribed over to their pharmacy. So those are things that are taken care of. Well, I think you get a more concise, a more comprehensive, concise visit with your patient because you do have all the information there, as well as if they've seen other. As this process continues, what our hope is, and I believe you and I have discussed this before, is our hope is that if they see a specialist, instead of us waiting for that letter to come through where it's either sent to us or it's emailed or faxed to us, that basically that can automatically be downloaded into their record, because then the patient, when they come to see us, doesn't have to wait that week lag time or 2-week lag time for us to get the letter from the specialist into the chart, and also allows us to manage that patient quicker and more effectively, because if we have that immediately, then we know what plan of attack we need to do. And so they're not as confused, and I think that's a good point to be at.
Well, Dr. Bush, thank you very much. I appreciate you coming on today and talking about this, and appreciate your insight and your experiences.
Thank you.